Thank you, Dr. Duchenne. We have now in total 8 minutes for question for these 3 presenters. So if I may start with one small question, which I think you can comment quite quickly. You have a randomized study of some 500 individuals, although showing a benefit, although the duration is shorter and the follow-up is slightly more limited. What is your view on 5 milligrams of tamoxifen? How sure are you about the data? What is needed more, or should everyone be recommended to use that dose?
I'm sorry, I cannot hear you very well. Can you repeat the...
You presented data, the randomized data here on 5 milligram of tamoxifen, and then you compare versus the other study. You had a shorter duration of therapy, slightly shorter follow-up, and the patient number is more limited. How certain are you about these data? Are you confident that this could be recommended, or what else is required that you will have a greater certainty that this is a reasonable strategy to use 5 milligram?
No, I am very confident in this data. The study is not big, but we saw a significant difference, and the follow-up is not long, but is not short either. It's 5 years median, so some patients are already on their 10th year. I think we need to continue the follow-up to see if there is the carryover effect, which has been shown in full-dose tamoxifen trials, but I think our data provide a practice-changing result in women with intraepithelial neoplasia, and possibly will provide a boost also for primary prevention in high-risk populations.
Okay, I'm not sure that everyone in the audience share your, but of course I understand your optimism for this. Do we have any comments and questions? Yes, microphone number 6. Introduce yourself with affiliation and name, please.
Very nice data, and it fits very well to the model that tamoxifen is, I think, overdosed already. However, if you are going to show your data on endometrial cancer, did you adjust it for age, or was it unadjusted? Because we know from the Lancet overview 2005 that only patients above 55 do have a risk on endometrial cancer on tamoxifen.
Thank you. Yeah, no, we adjusted for age, so the risk predicted for 20 milligram was including premenopausal women. Otherwise, the risk of endometrial cancer is more than 4-fold compared to placebo.
Okay, Professor Rutgens from the Netherlands, please go ahead.
Emeritus from Amsterdam. For Fraser, for routine pathology reporting in DCIS includes, of course, size and grade, etc. It includes immunohistochemistry, routine reporting for every day for coming Monday.
Yes.
And so why?
It includes immunohistochemistry at some point. So it is not common to do this on the core biopsy because of the possibility of upstaging. But if DCIS is the final diagnosis after surgery, then we routinely perform it. Of course, we do it in invasive disease. The question of why is because of the option for hormonal chemoprevention.
Right. Second question. Indeed, you alluded to that the HER2 positive breast cancer in DCIS is particularly in the high grades, and that you can see that the associated invasive part is frequently not overexpressed by HER2. We see it quite frequently that the associated DCIS overexpressed HER2, but the invasive part not. What happens across this border? Just across the basal membrane. It's strange for me, but what happens?
Yeah, it is curious. The question refers to when you have concurrent invasive and in situ disease, and that is of course very common in HER2 positive disease. We found in our our retrospective series around 8% of cases where the invasive component was not positive for HER2, but the in situ was. I still think that the HER2 positive has the propensity to linger in the in situ phase where it grows freely and can spread. And presumably this is additional molecular progression that enabled an invasive phenotype in a small subset of HER2 positive DCIS. But it's conjecture.
Fatima Godos from Portugal, please go ahead.
Fraser, just for a quick clarification, when you say immunohistochemistry is standard and should be done, you're talking about ER, right?
Correct. ER, okay. We do ER and PR, but yeah.
Because unfortunately, I see very often a full immunohistochemistry panel done, including Ki67 in DCIS, and that's a waste of resources.
Agreed.
Question to Shelley. You mentioned a trial that in particular in young patients there was a quite high rate of contralateral mastectomies. Do you know what reason for these contralateral mastectomies have been done?
Right, so I think that's just a fascinating trend that we've seen in the United States. I think there are many things driving it, and we certainly know the patient population that is more likely to get the contralateral prophylactic, and they're usually younger women, women who have better insurance, women who have smaller cancers or DCIS actually are very likely to have contralateral prophylactic mastectomy. And it's actually a real concern because in some centers the rate of contralateral prophylactic mastectomy can be as high as 50%, which for a unilateral cancer. So I think there's a lot of anxiety, and there's something called the Angelina Jolie effect, which is that she had a bilateral prophylactic mastectomy and was very much in the media and the press about it. And I think a lot of women are driven by things that they hear that might necessarily be relevant to their condition, but the anxiety is what really drives them to do it.
I would like to make a comment here. Norman Woolmer once commented this when he gave one presentation. He was quite upset when he said that it doesn't matter how much science we put on the table describing, there is not a single individual in that situation likely being cured. We have the scientific data from randomized data, and what a Hollywood star apparently in some society have a huge impact on what the total scientific society communicate, and that is for me quite a scary development. Why do we do science? What type of implication should it have? And what conclusion should you make? And if Hollywood stars, how great they even are, they should not guide medicine. They should be movie stars and nothing else. That is good enough. By that, I think we should conclude the session. Thank you.